Right. Yeah. So we were here talking about the various ways to engage. And find us there. We're happy to chat with you today or another day. Next slide, please. And we have to thank Dan Buckman for doing the introduction here. And you're going to see some parallels between what he talked about and what I talked about, what I'm going to talk about now, but with a key difference. And then this afternoon, Dr. Masley and I will do 2 applied workshops. First, we'll focus on intersectionality and data sets, and the second, we'll talk about looking at race and ethnicity in relation to health equity and machine learning. Look forward to seeing you there. Next slide, please. So I'm wondering if there's anyone out there who's ever taken an anthropology class. So like Dan, he's a bioethicist, and myself, I'm a medical anthropologist. And I think the key difference between perhaps these 2 fields, because there's a lot of overlap, is that, bioethicists are interested in what is the good and the right and what we should do, and anthropologists are interested in why so often what is right never happens. We're very interested in not so much idealized practice, but what happens day to day in clinics, between people, in hospital settings, in real life. So the first picture there is from, I spent years working in Malawi on pediatric HIV, and I was interested in understanding why, despite tremendous global health effort to improve care for children with HIV, children still remain half as likely to access care as adults. And the second photo, Marta, Vance, is on my current project on fairness and machine learning at CAMH. And I'm specifically asking, how do various actors in this health system we call CAMH understand and think about dimensions of fairness and health equity in relation to machine learning? So I am asking these questions along an integrated care pathway for major depressive disorder, which is not using machine learning yet, but will obviously in the future, I'm sure, but using measurement-based care. So using data to make personalized and help tailor decisions for care. And so you're going to see me talk a little bit about some of those findings today, which are very preliminary because that project is ongoing. But it certainly has informed my thinking on fairness and health equity in mental health care. Next slide. So our objectives for this section in this lecture are to define fairness and health equity. What do we actually mean by these 2 things? The second is to learn key analytical frameworks that we can use to understand health inequities. And the third is to identify invisible power structures and biases that get baked into our data set. So this is going to be a preliminary, and we're definitely going to talk about this third objective more this afternoon. Okay. Next slide, please. Next slide. There's something missing. All right. So my perspective is critical, and this does not mean it's a criticism. And so I want to make this distinction, is that I want to urge all of us and invite all of you to think about the work you do and ways you do things in new ways. This is very different from finding fault with approaches or analyses and interpretations, right? So this approach assumes that truth is generated when analysis is rational, skeptical, unbiased, and based on evidence, which makes it considered factual. Whereas what I'm trying to do here is introduce new ways of thinking, sort of challenge perhaps ways that do things that might unintentionally harm populations we want to. Next slide, please. So some terms that we're going to use when talking about these, and that I want to introduce is first is the idea of an algorithmic system. And, this approach is informed by people working in science and technology studies who try to emphasize that it's not just an algorithm, technical system that gets built, but it's the people that surround that system, the people, the energy, the infrastructure, all of that gets built to support the algorithm. And how does that thinking larger about this bigger frame that surrounds an algorithm? So when I talk about algorithms, I'm talking more broadly about an algorithmic system and not about a specific algorithm per se. And two approaches that have talked about this are Kate Crawford's very recent book on the Atlas of AI, where she really tries to ground algorithmic systems in materiality. So where do the minerals come from that support supercomputing? And who are the people who manage these cloud servers? And what does it mean to talk about cloud servers that are actually very tangible server farms in the middle of deserts, for example? And we're talking not just, again, about the outputs of a clinical algorithm, but on how we design them, how we collect data, how we analyze data, how we build models, and how we deploy them and evaluate them in practice. So we're really trying to take a larger lens on this issue of machine learning and health equity and think about how we could introduce concepts of fairness and equity at various stages of research life cycle. Next slide. So I also want to urge all of you to think of yourselves as BRADs. So BRADs aren't just those little metal tools that you see on the bottom right-hand screen that connect, various bits of sundries of paper. But BRADs are the very people that keep algorithms working. There are a lot of you who may be working within algorithmic systems yourselves. And Nick Siever, an anthropologist who worked at Spotify, so he did participant observation of research at Spotify. He was interviewing one of the technicians and calls him Brad, right? And he says, Brad and his colleagues are not strangers to the life world. Their countless little choices hold algorithms together. They make algorithms responsive to the world. In the world of music recommendation, these people often argue that their human sensitivity is, in fact, key to their system's success. Knowing things about music, caring about it, makes a programmer better at their job because such things shape their choices and their choices matter. The algorithmic fabric has a huge weft. Here could replace knowing things about people, caring about people, makes a neuroscientist better at their job. And so I want to think of all of you, as people within the system. You're not just technicians, but you're individuals who know things, who don't know things, who are committed to some things, who value some things over other things. And this, in a way, to increase your knowledge about people, how health inequities come to be, and the ways that your day-to-day practices could be enhanced to prevent any future harms. Next slide, please. Next. So, one of the things that Dan also brought up, and that I think is probably on top of mind, and that you hear talked about a lot, is the ways that machine learning or algorithmic systems might alter how healthcare is delivered and experienced by patients. One of the main ways is that it is altering workflows and clinical encounters. So, for example, there was a study of Septic Watch at an emergency in the United States. And one of the things that study found was that nurses within this algorithmic system put in place to predict the risk of sepsis were suddenly in a position of diagnosing patients with sepsis, which completely upended the hierarchy of doctors and nurses on this unit, created unexpected problems, right? So, an algorithmic system doesn't begin and end when you enter data and spit out the results, right? That there is eventually an application in a real world setting. It is also collected by people, it's measured by people, and so on. Of course, it's also incubating new delivery models. We have seen this rapid uptake of virtual care models during COVID, and that is likely to accelerate. There's no putting that genie back in the bottle. But more importantly, there's a lot of interest by the patients I talk to in measuring, collecting, analyzing their own health data. So, for example, some of the patients I've talked to are using a lot of commercial apps, like this one here called Dalio, to keep track of their own depressive symptoms. This is a major transformation. In the past, doctors might collect this information, don't have access to our health records unless we explicitly ask for them. We don't into eye care, the notes they write about us. So this is an interesting way of thinking about health data, who owns it, how we use it. And in this sense, patients, there's an opportunity here for patients to be more involved in the collection and analysis of their own health data. A project that Dan, Marta, and I are involved in is thinking about all these new predictive tools that are being developed in machine learning. So not just about identifying, different kinds of breast cancer, for example, but identifying or pointing out, for example, the risk of suicide before a patient actually tries to commit suicide. What does it mean to predict suicide in that kind of way? And how do you build a way to intervene ethically and in a way that's meaningful around a predictive tool? And finally, of course, this is transforming what it means to be a doctor. Dr. Mullainathan has this great article called "The Algorithm Will See You Now," where he points out this very dramatized version of what it would mean to have AI in doctors' offices, and that it might be doctors becoming data clerks. Whereas we see someone like Eric Topol who argues the opposite, that AI should free up time for doctors to deliver more passionate care. At this stage, there's really no evidence to support either approach, and I think it's likely that we'll see a bit of both happening. But I think it's really important to think about machine learning and health equity in this larger context of healthcare delivery and the experience of care by patients and clinicians who are there at the on the front lines delivering. Next slide, please. Next, one of the things that we always think about is that, and again, this is inspired by, the philosophy of science and science technology studies. What is the relationship between humans and their tools, right? Do we build our tools or do our tools build us? And there, next, please. So as, Marshall McLuhan, Culkin talk about, we shape our tools and thereafter our tools shape us, or we build the kinds of tools that are representative of us, right? What does it say about us as a society that you're interested in building? As Dan said, these very technical tools to solve social and political problems in many ways. Next. And of course, algorithms inherit prejudice of previous decision makers. I think everyone here likely knows that data sets can be biased. I know a lot of scientists spend a lot of time trying to make sure those biases don't cause harm within their models. Next, please. But featureization likely reflects widespread societal biases. So featureization is something that I'm really interested in because at the end of the day, it's a person making choices, labeling choices about what they think is important, right? And that's often based on the evidence we have, but sometimes it's not. And so, all the Brads out there are making tons of choices about what they consider important. It's very unlikely that this is not influenced by our perceptions, our values, our understanding of the world in general. Next, please. And more importantly, that within algorithms, disadvantaged groups are often erased. So Marta and I are also involved in another rapid review. And one of the findings from that review around race and ethnicity is that a lot of, often when a patient group that's deleted out of the data set for having insufficient numbers has been First Nation peoples for a variety, mostly because we just don't have enough to build a model around. But what does that mean long term, right? To have a whole group, a set of people not represented anywhere in an algorithm. Next, please. And of course, Dan did talk about transparency as well. And this is sometimes called the intrinsic opacity of black box, especially deep neural networks, unsupervised learning techniques. And this makes it very difficult to hold algorithmic systems accountable. So if they make mistakes, how would we? And in a mental health care context, this is more important because we are often working with patients who might have frequent encounters with the law, so they might not have a lot of trust in the healthcare system in the same way that a patient at Princess Margaret seeking out cancer care might have. We also have patients, for example, with Alzheimer's who might not even know that they have been diagnosed with it. So this raises a lot of questions around how we hold accountable, who holds accountable, and for what exactly are we accountable to. Next slide. So within this context, and I'm sure most of you know this, that the idea of fairness has emerged in the computer science, especially as a way to grapple with previous concerns. And in general, this is a way that's used to measure and try and compare across what are called protected groups, like different races, ethnicities, genders, to understand how a model might perform across these groups. And while this idea has gained tremendous potential and a lot of publications over the last few years, it really is an idea that comes from the 1960s and 1970s, when computer scientists were first trying to understand the implications of desegregation in schools in the United States. And that was the first time that this idea of mathematical fairness appeared. And then about a decade ago, it sort of showed up again, and it's just grown exponentially from there. And just recently, U of T launched this HALT AI program. I encourage all of you to check it out, where you can submit an algorithm or your competitor's algorithm to it, and they can do an audit of it, using these fairness metrics that have been developed over the last decade to try and understand various different kinds of biases that get embedded into the model. So this is a very growing and interesting field. Next slide. But when I first heard about mathematical fairness, because I am not a computer scientist or even a statistician, is I didn't understand, right? Until I had never really, even though I use the word that's not fair or that's fair all the time, I never really thought about, well, what is fairness? What do we mean by it? And I'm guessing that most of you haven't either. Maybe you could share in the chat whether you've given much thought to this concept of fairness, but yet I think we all use it fairly. Next slide. And this was particularly confusing for me when I was first developing this project on fairness and AI at CAMH, was because, around the same time, there were various political campaigns using the notion of fairness to advocate for their concept of social justice. So, for example, there were students at Jane and Finch, claiming that their education cuts weren't fair because their schools were historically marginalized, and that by cutting cuts to their education, it was building on previous injustice, right? This is a very different approach than what the Albertans, my home province, were doing around building this fair deal panel, because they felt that, Alberta, with the highest GDP per capita in the country, was being unfairly asked to contribute funds to poorer regions of Canada. So they developed the fair deal panel to try and justify to the federal government that they shouldn't have to give so much. At the same time, I'm learning about the fair data principles, right, in data science, which is findable, accessible, interoperable, reusable. And I was just struggling with trying to figure out how all of these ideas connected. What do they have in common? Why are really different groups of people using the same idea to advocate for themselves, but in very different ways? And next, please. And that's because fairness is what linguists would call a strategically deployable shifter. Other strategically deployable shifters include the word diversity, sustainability. Those are the two big ones that I can think of. And basically, it's a concept that can mean different things at different times to different people, but it's also a very powerful concept. A claim to fairness, if someone makes it, leads to, because people have different ideas of what it means. If my conservative government in Alberta claims that it's unfair, I might believe them, because the word means a very specific thing to me. But when you really have to think about, well, what do they mean about fairness? And so this is where we've arrived, is that it's very, very important to have a clear definition of what you mean by fairness from the outset. And every organization and group of people is likely to have a different definition. CAMH, as a public health institution, is committed to fairness as a form of health and health equity, right? If you went to, for example, like the Center for Policy Alternatives, which I think is a right-wing think tank, they would have a very different definition. So next slide, please. And what this in computer science has been called, and is called the Impossibility Theorem. And this picture on the right is from a Dogman graphic novel, for young kids, and I'm reading it to my 7-year-old one day. And there is this whole section about the fair fairy, right? And it's a TV show, a reality TV show, where kids can take their claims to this fair fairy on TV and get justice, right? And the fair fairy tries to decide what each kid does. In this case, the kids were arguing over a snack, and the fair fairy was like, well, I'll give your sister a cookie then, because she didn't get a cookie. And then the kid's like, but yesterday she had 2 cookies, and everybody lost their mind. And really, what this shows is that it's almost impossible to make things fair, because there are so many factors that come into a decision around fairness. So what we can learn from this is, next please, is that fairness can never be reduced to a single mathematical equation. So while we might have we do have some very useful fairness metrics, those alone cannot justify a claim to fairness, right? And we should be very suspect of anybody or any organization who claims that their algorithm is fair because they've run one metric. Next, please. And that is because humans make decisions about the relative importance of different criteria and equity goals. Right? And to give you an example from my own work, the next, please, Marta. This is a comment from a psychiatrist that I interviewed recently, and he says, sometimes I worry that we prioritize getting patients through long wait lists quickly, rather than really trying to make sure each patient has the right clinician for their needs. And what he was referring to was that there are 28,000 people, I think at last count, on the wait list at CAMH for care. That's a tremendous amount of people. And from an institutional perspective, from a government funding perspective, let's be efficient. Let's try and get as many people as we can through, because there are so many people waiting who care. That's one principle of fairness, right? This is one idea of justice and equality. But what he's also pointing out is that we might be doing this at the expense of the very personalized needs of various patients. He related this example in the context of us talking about patients with sexual trauma and how there are very few resources at CAMH to support patients who are struggling with sexual trauma. So for him, this was a challenge that he wanted to support these people, but really didn't have both the time and perhaps even the resources on his own to make this happen. And this is, I think, a very ethnographic, what we call an ethnographic example of the impossibility theorem, that it is impossible for us to satisfy all the different notions of fairness mathematically. And so it is always going to come down to all the brads in the system makes this, within this larger algorithm, make an informed and thoughtful, ethical decision. Next. So one of the things that I did when I first started this project was really try and understand, what is fairness? What is this concept and what do we do? And part of the reason it's so difficult is because different people use it differently. And more importantly, people talk about it. They talk about different dimensions of fairness. So sometimes we're talking about fairness, we're talking about transparency. Sometimes we're talking about biases in the data sets, right? We talk about the fair data principles, but a lot of that is about open access science and auditing and making sure that there aren't any errors there. We're also talking about inclusion. Is the data set representative? Has everyone been included? Is it complete? Is it accurate? All of these questions come into play and people emphasize different dimensions of that. I'm going to come back to this because I define fairness as the social and political and technical process required to achieve equitable health outcomes. But of course, this raises the question again of like, what is health equity? And like fairness, health equity is also one of those terms that has multiple meanings depending on the context. Next, please, Marta. So what is health equity? Next. And again, it feels like you're in a tautological turn, but it's everyone has a fair, just opportunity to health care. What does that really mean, right? And I have interviewed scientists and clinicians and patients around what is health equity. And I hear very, very different definitions. But most often what it comes up as is access to healthcare. Like the first thing that people think of is access to hospital or access to healthcare. But I would urge everyone to expand their understanding of health equity. It's not just about access to care, it's about access to appropriate care, but it's also about access to means, the opportunities to be healthier. Next, please. And, it says something here like 10% of a population's health and well-being is linked to access to healthcare, right? So actually a very small percentage of what makes us healthy comes from having access to a hospital or a doctor. That actually the things that make us healthy are access to food, the neighborhoods we live in, our postal codes, the color of our skin, our gender, all of these factors come together to keep us and provide opportunities to keep us healthy. Next, please. So to try and understand this, we're going to talk a little bit about a case study on diabetes and depression. Next. So as many of you may or may not know, that Indigenous peoples living in Canada have higher rates of chronic disease than non-Indigenous people. In fact, they're the group of people that are most at risk of chronic illnesses across the lifespan. Next. And some examples of that are, they are 17%, 17% of First Nations communities living on reserve have diabetes versus 5% of the general population. They're also the highest risk for cardiovascular disease. So, for example, 76% First Nations women are 76% higher chance of having cardiovascular disease than the general population. So these are very high risk conditions for very specific people. And how I might understand this is within a syndemic lens. So next, please. So a syndemic approach moves beyond our common medical concepts of comorbidity and multimorbidity, because it concerns the health consequences of identifiable disease interactions and the social, environmental, or economic factors that promote such interactions and worsen. So in this case, thinking about what is the relationship between depression and diabetes, right? Is it bidirectional? Is it unidirectional? Like, how did it all come together? And also, what is its relationship to health equity? Next, please. So, to sort of illustrate this point, in class, if we had more time, I would show you this documentary called The Gift of Diabetes. And this movie was made by Brian Whitford, who's pictured on the right, a First Nations man from Manitoba. And this film is about his healing journey, right? So Brian remembers feeling depressed his entire life. He was raised by his grandfather. When he was around 6 years old, his mother, that he had never known up to that point, came to collect him and took him to Winnipeg. So off reserve, lived with her new husband and his stepsister. His mother was 14 years old. She had him. She got pregnant while in residential schools in Manitoba. And she never told him who his father was, so he never his father. And he struggled with his identity while living in Manitoba. He has this recollection of his first day at school where a teacher said to him, this is Brian, and he is an Indian. And he remembers thinking, what's an Indian? He didn't know, right? And he had to really he didn't understand what his teacher was trying to ask him. And he describes feeling deracinated, that he has lost, through this process of residential schools and colonialism, lost personal identity. And over time, his grandfather is shot at a drinking party on the reserve, along with his aunt, who is murdered by her husband. Another cousin freezes to death at another drinking party. And so throughout these years, he develops lots of anger and frustration in the world, and he has a really hard time with these feelings of resentment and frustration and sadness related to his life. But at this point, we meet Brian, who wants to sort of get his health under control, and he starts this process of trying to get better. And he approaches it in multiple ways. He sees a counselor, he goes to anger management, he sees his endocrinologist here. He does lots of things to try and address what for him is more complicated than just, a sugar imbalance in his blood, right? And there's this very key moment in the film where he visits his doctor and he's trying to explain to his doctor that he's struggling with, the diet, that he's really struggling with his depression. And the doctor interrupts him, just about, well, what are you eating for breakfast, right? Like, he's completely uninterested, like large of Brian's. And, you can see Brian just kind of become uninvested in the conversation. And I think, what's important to remember here is that for Brian, his diabetes is not just a metabolic disorder, right? That for Brian, this is part of a much bigger story to his life. This is about, we don't know this doctor, but perhaps he has a lot of patients to see, has a long wait list to know what the conditions of his work life are that make this hard for him. But we do know that in general, it seems like Brian feels unsatisfied at this particular moment. So this raises questions like, where do health inequalities come from, right? And it's not genetic or some underlying, genomic issue in First Nations communities, right? These are related to various systemic, structural issues that impact a group of people unequally. Next, please. So, a concept, and there are many. There are dozens of theoretical concepts for understanding health equity. And the one that often gets used is this concept of structural violence, developed in some ways further developed by Paul Farmer, a physician anthropologist. And thinking about structural violence helps us contextualize Brian's struggle with diabetes and depression, right? So we have this wider social and political and historical context of settler colonial. Residential schools are over by this time in Brian's life. It's not so visible, but yet their legacy lives on, right? It completely shapes his experience, not just of his entire life, but also his experience of the health system in general. We have various social policies and government regulations. So one thing that Brian did not talk about in the video, but I think is very likely, was Bill C-31. So his mother married a non-Indigenous man. And if you marry a white person, at this time, there was a law that First Nations women lost their right to live on the reserve. And so, it explains a lot about why he ends up in Manitoba at that time, right? Then we have this other layer, which in public health, they call the social determinants of health, right? So your gender, your ethnicity, childhood traumas, right? So the violence and addiction that surrounded him when he was younger, so those are concepts that might resonate with you. But then you also have individual behaviors, right? We have Brian's anger and his depression and his frustration and resentment towards his mother, for example, for taking him away from his grandfather, who saw as a loving parent. So all of these things come together in a way, in sometimes very unpredictable way, to produce poor health. And yet they have a profound impact on people's lives. Next, please. So maybe a more metaphorical way of understanding this is this, battle between David and Goliath. You have Brian, just this guy living in Manitoba, not rich, not influential, let's say, against these superstructures that surround him, like colonialism and racism. And, this is how, in general, social scientists sort of understand this relationship between individual and population health and larger societal, political, and economic structure. This kind of tension between these two things. Next, please. And we have a lot of theories for trying to understand structures. And, none of these are necessarily correct, but what they all do is point a lens on a specific dimension of these structures. So a Marxist approach would focus on livelihoods and how people make a living, class, income, socioeconomic status, right? And a feminist approach would think about gender, would think about masculinity and femininity and how this might influence health. Later today, we're going to talk about critical race theory, and you'll learn more about that. A political ecology approach might think about food system, how the colonial government completely destroyed indigenous food systems, and what it means then to be disconnected from the food that kept you healthy for millennia, right? And there's actually a scene in the movie where Brian goes home to host a meal for his grandfather where they eat traditional food, and Brian just feels healthy, and you can see it kind of like the symbolism of that approach. So there are various theories. All of these help us understand a very specific dimension of structure that surrounds people. Next. So we think of suffering or health inequities as structured by historically given, often economically driven processes that conspire, whether through routine or ritual, the hard surfaces of life to constrain agency, which we mean by individual choices and opportunity. Next, please. Next. And agency, it's important to think about it like this, because one of the things that anthropologists, one of our pet peeves, is like, we don't really like approaches that blame the patient for their own health problems, right? So, he should just lose weight, or, maybe if he tried walking to work, like all these kinds of approaches to health that focus on individual behavior change, right? Because we imagine and think of people within these larger systems, and always imagine people are constrained by a variety of things that are visible and sometimes invisible, right? So it's not really freedom. It is freedom for meaningful action, the ability to make one's own choice within these constraints, right? And constraints can include lots of things, not just colonialism, but marriage, geography, religion, workplace, gender ideologies, for example. So there's a whole variety of things you can think of that might. Next. But this raises a conundrum. So one of the challenges with this approach to understanding health is that people resist, right? So people do fight and do stand up and do, display what might be considered freedom and choices, right? And so that, throws this, this kind of neat model of like bigger structures influencing their way. It's not so top down. It also doesn't explain why these systems persist, right? We know that colonialism and committed violence against First Nations communities, and yet we still don't really have any major action on the true calls to action. So, despite even awareness or knowledge of issues, might not see any real change. And I think this raises us into the center here, which is this idea that sometimes the problem with understanding health equity this way, in this very broad, systemic way, is that it diffuses responsibility. Well, I don't know, like, why bother? Like, that's colonialism, it's over, we solved that, so this issue will just fix itself, right, for example. Next, please. So, and as Hooker, I think, though, says very carefully, is like, in computer science, diffusion of responsibility often revolves around discussion of what is and isn't out of scope, right? And I've heard this before. It's like, well, that's just beyond the scope of this project. And that is a very fair, pun intended, statement, but it's also one of the reasons that perhaps we don't see as much traction on these issues as I would like to see, for example. Next. And so this is my invitation to you, right? So, in a previous workshop on this with neuroscientists, someone asked me, is there truly a disconnect between studying the brain and studying the societal causes of illness, as long as one isn't confused with the other, right? In a way, this is a version of beyond the scope, or stay in your lane, stay in my lane. And I would say, okay, like maybe, but are our perspectives really that far apart? Next, please. So we know, what we even know about biology and the brain is that you can do all of them. I think there's 4, Marta, that show up. Is that we know that the environment, the way we were raised, affects, the structure of our brains, right? We know that it can affect our genome. We know from twin studies that twins who have identical DNA can have very different experiences. And so I would ask, are we really that far apart in a way? Are we really in 2 different lanes? I don't think so. I think we just have 2 different lenses on. And that there is a way. I'm inviting you to think about a way to think about connecting these 2 areas more explicitly. Next. And so to sum that up is that really what I want a key takeaway for everyone here to have is that our material and social worlds result in uneven population patterns of health and disease. So when we see uneven patterns, we are really talking about social and political structures that influence people's choices that result in poor health. And so sometimes I attend many talks held by neuroscientists all over the GTA, and I often see some variation of the slide here, right? That let's focusing from the genome all the way up to the person. Next. But I would again urge us to think about how all of these factors are influenced by our environment, our economics, our culture, for example, and try and think more deeply about health equity, even from the perspective of science. Next. So I think a better way, in some ways, of thinking about this, a more helpful way, is to think about it as a form of social suffering. Next. So, of course, first is to acknowledge that our socioeconomic and sociopolitical forces at times cause. Next. And that social institutions like hospitals can make suffering worse, right? So, you see this painting by Kent Monkman about the RCMP and the Canadian government's role in residential schools in Canada, right? So here's an education system directly involved in the destruction and genocide of by dozens of First Nations peoples. And hospitals, in a way, are part of that process as well. There are plenty of examples of First Nations patients, for example, being treated poorly by clinicians, right? So there are situations where going to a hospital and access to care might actually cause harm for some groups of people. And that's always important to keep in mind. Next. And that importantly, that suffering, disease is never just an individual thing, right? So when you are ill, Brian was ill with depression. It actually led to the breakdown of the relationship with the partner, right? So our suffering extends outside the individual to include our family. You wrote this very clearly with a patient who might have advanced dementia, right? They really have no recollection of their diagnosis or maybe what's going on, and yet their family and their caregivers are intimately aware of and struggle deeply with trying to manage that person's suffering. In my own community, I live in a community where there's someone living with a drug use disorder, and it resulted in the death of a young community member last week. And that death has led to a lot of collective trauma with my community. tragedy, a lot of suffering for people who were witness to the death and aftermath. Next. And I think the important thing is that it collapses the distinction between what is a health and social problem. These silos aren't as clear as we might like to think. Next. So what this leaves us with is, how do we actually operationalize fairness? What do we mean by fairness in the context of ML? If it's about achieving health equity, how do we actually happen, right? So I think first, again, is to collapse the distinction between what is a health, what is a social problem. We have to think intersectorally. So how do we, cross boundaries of health and education, or health and, civil society, for example. We have to often be interdisciplinary. So, Dan is a bioethicist, I'm an anthropologist, Marta is a psychologist. We have very different lenses onto very similar questions, but that can be a very productive way of trying to understand these things. And from my perspective, medical statistics are my friend. I don't collect them, don't analyze them, but they are certainly useful for trying to understand health equity, measure them. When done correctly, they can be incredibly powerful. And I think there is a lot of potential in machine learning to advance questions of health and to try and address some questions. Next. And so returning back to these three pillars, what do I mean by 3 pillars for fairness? How can we do this in machine learning? Next. And, I'm going to piggyback off of what Dan said, but also slightly differently. And so next, so when you're reading the literature on machine learning and fairness and health equity, of course, transparency often is one of the main issues that gets brought up. And it's usually in relation to this idea of this black box problem, right? So this idea that machine learning algorithms are impossible to understand beyond, mathematicians who might have really advanced statistical skills. And so this idea of interpretability comes up, and I think of it as a set of procedures and tools and techniques used to test, validate, and analyze models, findings, and so on. And you will hear some excellent and I think really world-class examples of that at KCNI summer school. There is a group of scientists here really committed to open access science, to the fair data principles, to really thinking critically about the biases that might enter their data sets. And this is, I think, this is all really excellent stuff that you can hear about. The thing is that someone like me doesn't necessarily understand all of that. I don't think it's necessary for someone like me or the average person to necessarily understand what all of these metrics mean or why they might be important, but there has to be a sense of trust that these metrics exist, that there are standards being upheld, that there are people being held accountable when these standards aren't held, right? So this relates to explainability, which is the next dimension of transparency, right? So perhaps a little unlike Dan, often in the literature, especially in the computer sciences, these ideas are used interchangeably. They're not always explained or they're not always defined appropriately, I think. And so I would argue that interpretability is this, technical process. This is the best practices in science that we're going to see. But explainability for me is something completely different, right? It's about engaging publics, as Dan says, patients, clinicians, in trying to understand and translate the purpose, relevance, and limitations of an algorithmic system, right? So this isn't necessarily about being able to know which features were used to create the model or were most relevant. It's not necessarily about getting into the details, right? But it's about being able to explain in a clear, concise, accessible way what is going on. You can see in the vaccine hesitancy debates right now, for example, around COVID-19, I have a neighbor, for example, who refuses to get it. And it's partially because she just does not understand what mRNA vaccines mean. And partially it's because there aren't necessarily, for her at least, great examples that she can understand what this vaccine and why it came out so quickly, right? This is the part she just can't get over. So if there was some way to explain this process to her, someone who didn't finish high school, I think it might, really help. And this is about acknowledging the power dynamic at play between knowledge makers like scientists and knowledge users, which are, in our case, again, a lot of patients with really complex mental health problems that intersect with criminalization and homelessness and already social marginalization. So next. And finally, I would add accountability. So transparency becomes important in fairness because you have to find a way, what happens when something goes wrong. And I would say that this is sort of the missing piece in a lot of ways, is that, there's a lot of auditing of algorithms that goes on, but even when a problem is found, these algorithms aren't necessarily taken out of circulation, for example. So for example, some of you might know of the Compass tool that the United States assess people who've had an encounter with the law at their likelihood of recidivism, right? So the likelihood of them committing a crime. Well, that algorithm was found to be biased against Black men in particular, which shouldn't really be a surprise because they used a proxy, which was an encounter with the law to predict recidivism. But we know that Black people are, unfairly profiled by police. So, but even when this was found, this tool remains in use, right? So judges are just now urged to use caution to recognize this is a limitation. The tool itself is still used, it doesn't change. So we cannot confuse transparency with accountability. Those things are two separate things, and just because you can see or know that the algorithm used good scientific practices doesn't mean that it can't cause harm. Next, please. So the next dimension of fairness that is relevant to machine learning in healthcare is this idea of impartiality. So there's this idea that algorithms, if their data is clear and precise and unbiased, that you can just, that it should be all of these. But that's obviously really hard to do for that's already. Next. And so to satisfy this criteria of fairness, we have to think and understand the origins and limitations of any given data set, very broadly defined. So this isn't just about, measuring how the algorithm might perform across a protected group, but it's also about understanding why each of those labels were picked, how the features were picked, why they were picked, the values behind those labels, where we start. Next. And also, so the algorithm doesn't end when the results are good, right? We have to think about what extent a model can be deployed in a clinical setting without reducing and or creating health inequity. And this really remains an open question because very few tools have been deployed in clinical setting. And in fact, a lot of tools that they've made attempts to deploy have failed. I know Dan cited McCradden earlier. McCradden also has a very good paper around how all algorithms should be deployed using silent mode prior to the official deployment. They should always be evaluated in real world context before their actual official rollout healthcare. And so that's what I expect that we'll start to see more of those kind of studies moving forward, is trying to understand how exactly this happens. So the example I used of Septic Watch, for example, how once it was deployed in the clinic, it kind of like upended this imbalance between doctors. Next, please. And finally, the third dimension of fairness is inclusion. Next. And one attribute of inclusion is the idea of completeness. So collect necessary data on marginalized groups to perform audits of model function, right? And this is a very, very, it sounds simple, but this is a very difficult criteria, right? And that's partially because access to healthcare is uneven, right? And so it's unlikely that any of our data sets that are collected at a hospital are actually representative. And then on top of that, that groups that are most likely to maybe have poor health outcomes might also be underrepresented in these models. And this sort of demonstrates the brittleness of machine learning, right? Because once like the number of features that are in the model are there, they go down, then the less accurate it becomes, right? So this is actually, I think, a really thorny, sticky issue that is very difficult, I think, to answer only from a machine learning perspective. And this is something I would urge people to think about, is that how work with small data or qualitative data, perhaps to help fill out gaps, because in some ways you'll never end up with a fully representative data set. It just probably will not be possible. Next. And of course, I think it's not just about making sure that data sets are representative. It's about making sure that people are actually engaged in collecting, understanding, and thinking about data, right? They also have to be involved in thinking about acceptable fairness standards. So how would they like, what kind of fairness metrics would they like to see? So as an example, from a patient that I interviewed recently, Marta, he was specifically talking about how data is used to manage his depression. So he says, I want to know what assumption the psychiatrist is making based on that data, right? So quantities aren't of any value without qualitative scale. And my qualitative scale is going to be different than his. So data is useful as long as I'm looking at it through the same lens and interpreting that data in the same way. And we can have communication regarding whether or not we agree on what this all means, right? That closing the loop, so to speak, bringing that back into view of both parties, I think, is pretty crucial. I think he sums this up really well, is that, without closing the loop, without really bringing patients back into this lens, we're likely perhaps to make amplified harms. Next. So some key takeaways is that, one, equity matters. And, and I really appreciate that Dan asked you to try and rank your ethical principles, select your favorite, the one that you value the most. And in my head, I was thinking it was inclusion and equity, that this was the value I saw as being the most important. And it's important to think about this, that there are trade-offs behind different principles. Just as the psychiatrist, perhaps forced to sacrifice quality of care for quantity to move people through, there are trade-offs between different dimensions of fairness, and that we have to put them all on the table. We have to be quite transparent about what it is we're trading off when we make a trade-off. And, we need to involve different groups of people in these discussions. Otherwise, we might, I think, run the risk of losing patients' trust in our health systems, right? As these, algorithms could become the next vaccines, right? That if the science and the communication isn't done correctly, people might start to get become hesitant, might start to become suspicious of their doctors, of their health systems, of the ways their data is. So we're really at a critical point where we need to think about how we're going to move forward to make sure that people understand what is happening and how, what is the benefit of that and what is perhaps the negatives. So some key takeaways here are, next, Marta. Health problems are social problems are health problems. I don't know how to distinguish between the two. And I think that even though it might seem like they're separate things, I don't think they are. Next. I think advances in ML hold tremendous potential for supporting efforts to achieve health equity. Of course, I've introduced critical perspectives here and some caution, but I'm also, really excited to see computer scientists engaging in these questions in the last decade. I think I've seen a lot of very exciting and interesting interdisciplinary papers come out trying to work together to advance questions around health equity. I really appreciate that there are teams of people trying to think critically and work together to solve these problems. Next. But of course, these advances could cause harm. I've talked about some of them. Dan has talked about some of them. I'm sure many of you are aware of some of them. And I think we can only, right now, we're, in a way, running blind. We really don't know enough to know. And it might surprise us the kind of harms that it could create. So it's really important to be paying attention, to do these evaluations, to do research on what happened. Next. And of course, I think you should realize now that fairness is more than a good mathematical equation or a good metric or, doing an audit. That's part of it, and that's a really important part of it, but it's not the sum total of it. Next. And of course, I think fairness is not just about having open access data sets that are findable and all that, and that's one part of it, but it's also about how we sustain dialogue, democratic dialogue, involving different groups of people, about machine learning and what it might do, how it might transform medical care in Canada. And I think that's it. Next. Oh, and of course, I think I really support collaborative, interdisciplinary, and transparent science will facilitate the uptake of machine learning and effective and fair use in healthcare setting. So if there are any questions, I think we have about 5 minutes to address them, and I'm happy to do so. One question. Ask a question. Is there a disconnect between what biases, processes can be observable and explained with evidence-based science and what a societal group may be experiencing qualitatively, maybe because of academic biases and trusting standardizing phenomena that are considered acceptable by privileged groups? Yes, absolutely. So, Hadjit, I hope I'm pronouncing it correctly. I think a really good example of that would be around race and ethnicity, which Marta and I are going to talk about later today. And there is a very big disconnect between how we measure the impact of racism on health outcomes versus how people experience it and of racialization. We're going to talk. I think that's a really good example. Is that how, for example, a marginalized group or racialized group may define themselves very different than how the NIH defines them. And what does it mean to define people for them versus have people define themselves, right? I think that's a very powerful example, and we will definitely be talking about that later today. If you want to discuss it further, we could bring you on stage, but I hope I answered your question. Anybody else? Okay, good. Thank you. All right. I know it's around lunchtime, and we will be around all afternoon, so you will hear plenty from me and Marta later, and have lots of opportunities to talk to me as well. So could close early and have a slightly longer lunch.
Any last questions for Laura? Okay, maybe everyone's hungry. All right, well, thanks so much, Laura. That was great. And we will pop into GatherTown as well. if you have any questions. Oh, Dan has a question, actually.
Why do you think fairness is gaining such prominence in the field? So I actually think it's because there are a group of young computer scientists who are interested in social justice issues. So I actually think this is why it's kind of exciting, because I think we're at an interesting moment where there are people studying math and computer science who want to kind of get at some of these issues, who are interested in this. And so that's why I think. But maybe other people have a different idea. I've seen some really interesting and informed and thoughtful presentations by computer scientists, for example, at U of T, who are really trying to engage deeply in these questions. From what I've heard see in the field, that this wasn't the case 20 years ago. So I think it is kind of a turning point or a pivot in the discipline itself. Yes, and Erin said that there's we can also chat in GatherTown, so there's also that opportunity. All right. Okay. Well, we will see you. I think our next session is at 12:45. Is that correct, Marta?